Welcome to today's conference, 2025 Behavioral Health. I am Jenny Brandel, and I am going to be doing just some quick introductions before we get started today. And just a quick start, a kind and warm thank you to our speakers today for sharing their wisdom with us today. This conference comes equipped with tools for our own personal tool belts with proven methods, strategies, and really just some great information. So thank you, everyone. And thank you so much for everyone for attending today. Our first speakers today are Dr. Joseph Kent from our very own Methodist Fremont Health and Danielle Dorman, a nursing practicing consultant with DHHS Board of Nursing, speaking about conversations about LGBTQ. Thank you guys so much.
Thank you. We're really delighted to be here.
So several of you have been to our talk. I think this is our third year of doing this. So we have added quite a bit. So we do have a new case, a new patient kind of population focus there. And we also have quite a bit of updated data and kind of educational information as well. So if you've heard this before, there will be quite a bit of new things, but we should be able to adding to kind of what you already know. So adding to your base. So I guess just some basic background. So I have specialized in gender-specific mental health, transgender patients for the past 7 years now, including opening 2 different clinics and some specialty training.
And some of you know me. I used to work with Jenny Edmondson as the practice consultant and am now at the Nebraska Board of Nursing with DHHS. And I am bound to say that the views that I am sharing are not necessarily those views being represented formally by Nebraska DHHS.
Our views are purely our own.
And we are sharing generously with you all today.
All right, let's jump right into the case here. So our case today is Jose, 17-year-old boy presenting for nausea and vomiting, accompanied by his mother. You've seen Jose in the past for sports physical, but nothing too intensive. Mother reported that Jose had been getting worse grades, not interested in soccer, really kind of detaching from their normal behaviors, worried that they had been acting differently for over the last year and become more withdrawn. So kind of to open it up to the team, what are some of the key questions that jump out right out of the gate?
And if you've been, oh, go ahead.
Oh, I'd want to know how he's eating. Has his appetite changed or anything?
Okay, so getting more details on the kind of the physical side of it. Okay, anything else that it jumps out to people that they would like to know?
This reminds me of just the brain gut connection and just how his mental health is affecting his GI system.
Absolutely, especially when it does come to depression, anxiety. I'm sure we've all had those really high nervous days where we can't eat, can't sleep, can't keep food down. Now, imagine if we lived like that every day. Very good. Okay, anything else big before we move on here and start getting more information? Okay.
Okay.
All right, when you start getting more information from Jose, he explains to you that he actually goes by Josie with his friends. So what difference does this make now that you find kind of early in the case that our patient is actually transgender? I think one thing that's really important to keep in mind here, especially when talking about a minor, which we'll go into more detail about this, but Josie being 17, one of the big questions that we often run into, especially with very sensitive information like this, is how much are you going to tell my parents? Maybe the parents don't know, maybe they do know. So that'd be one big key for us to talk about. One of the things that's a really good starting point there is kind of just figuring out what that relationship is like, right? What do they know? What pronouns are used at home? How do we actually interact? When you did speak to your parents, how do they respond? And definitely understand too, especially when we come into Hispanic families, very tight-knit family units. So we may also want to ask, how are your grandparents responding to this? Aunts, uncles, cousins, how is your overall family unit? It's not quite as simple as what's happening just in your direct mom, dad, siblings there. Other thing that's definitely going to be important when kind of prepping the patient as far as kind of information to kind of help ease their mind, talk to them about their rights, especially as being a youth. pretty much what I usually like to explain to them is anything that you and I talk about, as long as you're not going to hurt yourself or other people directly, I'm not going to disclose unless you and I know that we're going to disclose this, and we will probably do this together so that we can have this conversation as more of a family instead of just me and you or me and dad, because we don't want to create that divide there. Any very specific kind of social or sexual history questions that you guys would like to ask? I guess I'll
I'm
lead a
curious
question.
what
Oh, go ahead. Go ahead.
sexual history or what sexual preferences Josie has at this time, and if that's been discussed with Josie's parents and where that kind of base is right now.
Very good. So yes, this kind of gets into the aspect that our sexuality and our sexual identity, you know, kind of preference versus who we are, do not have to be, excuse me, are not the same thing. So kind of understanding where they are, it also can help us understand some of their risk, right? We still have to worry about STDs and pregnancy if we are genetically female, prostate and those kind of things if genetically male down the line. Okay.
In the chat, it says, any history of abuse in a relationship, what kinds of things has he been interested in growing up? Just so you know what's in the chat.
Perfect. Thank
Thank
you. Because
you.
yeah, we cannot see that as we go through this. So yes, those are very, very good, especially when it will come to kind of some of our education down the line. But the rate of being abused for be that sexual abuse or even just assault is much higher in the transgender population. So getting that background as well, but it also helps you establish how safe are we at home, right? What is kind of our situation? Are we safe in our relationships? Are we safe around our family? Very, very good, because yeah, that could add to a lot of other diagnoses we need to help with, PTSD being something we do not want to miss, especially in this population here. Okay, very good.
Yeah, so the age of the patient in this case study is 17, and the age of majority in Nebraska is 19. But having just recently started at the state of Nebraska, I recently learned that there is a very specific law in Nebraska. It's statute 43-2101, that 18-year-olds in Nebraska who are seeking or under the care of a behavioral health provider can independently seek and consent to care without patient notification. And the purpose of that law is to bring the state of Nebraska more closely aligned with the other 46 states and Washington, D.C., who have their age of majority set at 18. So Nebraska, Alabama, and Mississippi are the only 3 states in the United States that do not have 18 as the age of majority. Alabama is 18 and Mississippi is 21.
Alabama's 19. Yeah, you misspoke.
Alabama's 19. Yes.
That's why it's teamwork, right?
Yes. Yeah. So there's a trivia for you.
Yeah, and I've actually brought this up with some of my younger patients in the past who've been talking about coming to the hospital to kind of let them know, because it's one thing to be able to tell them like, oh, we're not going to tell your parents anything and, you know, et cetera. But being able to actually tell them like, here is your rights. Here's what you know. Plus, as I'm sure you all have seen, I mean, just being that knowledgeable expert for your patient can really ease their mind, right? I'm in the right place. I'm with the right people. You actually can help me, especially in this population when many times they have been let down over and over and over again, especially by healthcare workers, which we actually have a whole slide about here. For the bottom here, you know, we have just been kind of informed about well, about not even pronouns in this case, but appropriate name here for our patient. So this kind of gets to that gender affirming language in healthcare settings. So I think one piece, I'll kind of answer this a little bit on our own as we go because we don't have so much time, but kind of identifying those pronouns early, right? Even just asking patients, what would you like as far as pronouns here? And when it comes to a younger person, I also like to clarify, what pronouns do we use in front of your parents? What do they understand? We don't want to create a conflict right here or out the patient accidentally if the parents don't actually know kind of what's happening. So there's a lot of concerns here, which makes it where it can be hard for patients to be honest. They're healthcare providers, and you know, we can only help with what we know.
Absolutely.
Okay, so some more background here. So Josie explains that school has been really hard. A lot of bullying, doesn't like going to school, tries to get out of it. The nausea and vomiting is only on weekdays, not on weekends. Josie also describes the vomit as this kind of foamy, green, yellowish, more bile type. No blood. Has taken a Jantotron a few times, but once it wears off, it comes right back. Does not induce the vomiting and is not trying to lose weight on their own. They did explain that anxiety has been very high, and they often do not feel that they belong. Abnormal findings: there is quite intense bad breath when checking, and then there is a well-healed superficial scar on the bilateral posterior surfaces of the forearm, which ends up being self-induced. Okay, we'll open this up to kind of the different team members, and we have people from all over. I guess any big things that you want to know about for your specific field at this point in the case?
I'd be curious from a nursing perspective, just as I'm doing an assessment, if there's other markings elsewhere from a self-harm perspective, and how deep and those have been and when they were and how frequently they're being done.
Very good. Plus, we'd be looking for signs of infection, right? How are we doing about cleaning this? And one thing when it comes to that, having that conversation in a very almost matter of fact, I had this conversation every day type of kind of an angle of vibe there with them, just kind of asking, okay, when we do this, what are we using? All right, is that clean? How are you kind of handling the wounds afterwards? Coming at a very neutral, I just trying to get the medical facts kind of thing where it doesn't seem like what I'm doing is abnormal. It also gives a very good opportunity to see if there are even bruises, things that maybe don't quite line up with the story. Okay, very good. Why do we think we have dental on here specifically? Any ideas there from anybody?
I think the halitosis could be contributing and stuff. How are her teeth? Is she throwing up? Is she binging, purging, that kind of thing?
Right.
It might also show,
Oh,
I'm sorry,
go
it
ahead.
might also show drug use.
Very good. There could be multiple things here. And even though the patient did deny inducing vomiting, do patients always tell us the truth? Not always, especially in these hard cases that are pretty sensitive. So that can give us that backup information. Also, your chances of dental caries and these kind of things if we're not doing proper self-care, signs of infection, all these other pieces. For some of the other ones that we'll kind of answer for you, case management, definitely talking about support, outpatient care. Do we need to talk about the safety side? On the dietary, yes, what are we eating? What is our diet like? Is it that we're having a very unusual diet for some reason that is leading to this nausea, vomiting, etc.? On the pharmacology side, are we taking any supplements, especially as we're kind of on the gender piece? Are we trying to have some natural estrogen boosters or testosterone blockers in this case, right? That might be factoring in. And then on the mental health side, we've mentioned the depression, anxiety, but also just this very thorough history about mental health care, suicide attempts, etc. Okay. We mentioned a little bit of the cultural considerations because we want to be understanding of everybody. And one of the big things that I've kind of added this slide for is that understanding that this population that is already kind of isolated and kind of on the outside, really, you have that factor, but you're also going to have other pieces. You may have that in this case, being in the Hispanic community and transgender female, that there's going to be an interplay there. Some of the big parts, the strong family bonds we talked about, and that patients will often kind of prioritize the needs of the family over themselves, where this tends to be seen as, I can never come out until my parents have passed away, until my grandparents are gone, until I've left the family, just because of how much it will kind of hurt them, and if you're being pushed out there. The gender roles are also more set in this population often, where they're much more traditional. So breaking away from that, especially within the family unit, can cause a lot of problems, a lot of very awkward conversations at the very least, and homelessness, abandonment on the far other end there. As far as the religious side, there is very strong Catholic influence as well, which can lead to pretty much all these things we've talked about, and a lot of this kind of internal kind of guilt and shame that comes with it. When it comes to more the communication issue, Spanish is a very highly gendered language. So it does make it where this gender neutral communication with our patients who identify with neutral pronouns can be very, very difficult. So making sure that we do have an expert there with us using a translator. Some of us have a little bit of Spanish, but especially in situations like this is where we bring in our team. This is why we have the experts and we use the Marty and these type of things. Okay, so some other pieces that can make things hard is, do we have multiple other kind of pieces on this too? So the immigration status, are we undocumented? Is there a language barrier, as we mentioned? Do we have insurance, especially with the changes in kind of Medicaid, Medicare that have happened more recently? Have we recently lost insurance? We were getting healthcare and now all of a sudden you're not, right? And then discrimination, be that in the workplace, the community in general. When it comes to being transgender, as a general population, much higher rates of various infectious diseases, including HIV. So there is that minority stress part there. The lack of culturally competent care is a huge piece. It's partially why we're talking about this here. I know it's something that our organization has been very focused on. So I definitely applaud that. Want to put that out there that we're doing some pretty good work there. As far as immigration goes, people do really, I'm sure we've run into this already, but get really nervous when coming to the hospital if maybe there's some question about their status, or do they come at all? Do they tell you kind of partial information? Do they give you someone else's info? I've had one case where a patient came in giving information of what ended up being like a cousin, because the cousin was documented, even though you were not this person, so that was a whole different legal discussion to have there. This fear of being deported and taken right away from the hospital is very, very real there. All right, follow up 2 weeks later. So Josie started with therapy and outpatient psychiatry. Depression and anxiety are found to be improving. Family is using feminine pronouns, and the patient actually joined a local sports league trying to gain support here in the community. And that is a very real thing, by the way. There is a very strong LGBTQ community here locally, including a sports league, because patients want to have unity and do all these fun things that everybody else does, but in a calm, comforting environment. And you do not have to be LGBTQ to be involved in this, by the way. I've been involved in this in the past just as an ally, and it is really, really, really fun. And it gives you a chance to kind of learn and meet people outside of what might be your normal everyday experience there. Other big pieces, weight is stable. They have started nutritional supplements. Joined the River City Gender Alliance, Heartland Pride, trying to kind of really build their community and make a difference. And as far as long-term improvements, they were planning to apply to UNO and had actually been doing better in school, returning back to school, which is always our key, right? We're not here just to get people by, but we actually want them to thrive. We want them to make their community better, make things better for themselves and their family. So that was a huge piece for us. The school had been informed about the bullying that was happening there as well. And sadly, I'll tell you, because I don't want to expose any one school or another, but the districts are all over the place. Even within OPS, some of the schools are all over the place as far as how supportive they are of their students, how much they look the other way. This is a big problem, actually. Called some of my sources over at Boys Town to talk about this, and we could have a whole lecture about the kind of problems we have within the state here. Okay, so even in our kind of discussion here, shifting between patients, and not even in general, but also in your own cases, do you find that kind of changing pronoun is difficult for you with patient populations?
I think they, them is a little more difficult because it's not a normal speaking pattern for me. Doing he, she generally isn't. I also have found that if you're honest and say, please correct me if I do, or if you own up to a mistake, that most of the time the individuals are much more forgiving and understanding.
Absolutely. Yeah.
Yes, very good, Dessa. And I guess I'll lead into a next question. So if you do make a mistake and they don't say anything about it, but you notice it, now what do we do? We scared Dessa away.
I'm sorry, my voice, I'm trying to save it, but I always apologize. And I have like I said, I found, because I actually just had this experience with a colleague of mine, that she pushed a patient away because she said like good girl or something to someone that was gender neutral. I had dealt with the same person and had made a mistake. I said, I'm so sorry, apologize, and we were fine.
Yeah, it's a great example.
Nothing's a big deal.
Yeah, because even some of this phrasing that may not necessarily mean to really be gendered like that, you know, a good girl when you're trying to say, you know, good job, you know, positive affirmation, that may actually come off, yeah, very offensive. That's a great example there.
I also think it's awesome when, as a team, you call each other out when you may have mistaken the pronouns or the preferences. One, it holds everyone accountable, and then if you feel safe in your team, it's like, oh yeah, shoot, I'd rather make the mistake here than with the patient.
Yes, and when it comes to kind of the inpatient side, some of you have been on these team meetings with me. I do like to kind of preface that when I'm introducing, you know, a patient, right? I give that history of Josie's 17-year-old transgender female. Here's the pronouns. We're going to get it right every time. If we make a mistake, we're going to own it. It's going to be something across the board. If we notice anything that is, you know, consistently incorrect, like please let one of us know, you know, as far as administration or myself, and we want to kind of correct that, really showing that we are dedicated to this together. And then it makes people feel a lot more comfortable too about saying something down the line if someone does make a mistake, right? Knowing that they're supported by the hospital administration. Okay. We talked a little bit there on that second one, as far as the rights of the patient, always important. The parents also will all ask about that because they may want to know more than the patient's wanting to disclose. To be able to tell them that is always important. As far as the sense of trust, you know, we're kind of hitting on a lot of this piece, trying to kind of really establish that early, showing that you are going to try, you do care. You know, this is important, showing that you do have some education, even if it is small. Really kind of laying that out there. And that first interaction when you first meet them is so important, which I think we're actually going to get to here.
Yeah, and making those corrections in front of the patient is a great way to help establish that trust.
Yeah,
because
yeah.
it shows them that you're trying.
Yeah, own it, because they notice, they hear it, even if they don't say anything.
Right. Right. So this last point, some positive and negative aspects of patient care when focusing solely on the patient's identity, is kind of transition us into the second part of our presentation. But what kind of pitfalls would you anticipate focusing, you know, just on like an outward expression of gender identity?
And just the basic, like Dr. Kent said earlier, educating on pregnancy and prostate and stuff like that. If you're just focusing on what they identify, you may forget the basics of how you care for a person that is biologically different.
Absolutely.
Yes. Yeah, your breast cancer rates and all these common things. There's, you know, family history, even when you're there asking about if it's, you know, genetic female, asking about mom and grandmother, etc., versus kind of mixing those lines up, essentially getting that useful information.
All right. Before we transition into kind of the second part of our presentation, any questions thus far? Anything that someone wants to ask? We can't see the chat, so you'll just have to talk to us.
There's nothing in the chat at this time.
Okay, great. Fantastic.
I have a question.
Yes.
So as far as kind of going back to that, working in the ER, you know, if we have some of these things that we have to ask about, like a menstrual cycle or some of those like gender specific questions that we would need to know for certain complaints, what is the best way to go about that if maybe they are female identifying as male, but you would still need some of that information for a pertinent history?
That's a great question. So there's really kind of two ways I do about doing that, and I kind of incorporate both. One is just kind of explaining to them, right? Definitely understand that we're, you know, transgender male. However, you still have a uterus. Here's the risk that we have. Boom, here's my questions. that's one. The other is kind of the way that you go about it, right? If you're really uncomfortable and you're kind of tiptoeing around these questions and making them awkward, they pick up on that, where it should be like you're asking anybody else. When was your date of last menses? Boom. Have your cycles changed? Just these very almost matter of fact, right? Because we ask this of every genetic female, to where we keep it that way. But just kind of explaining to them, this is why we want to know this, showing that we care about your health from who you used to be and who you are now. We care about all of that. That's a great question. Any others? Okay, if stuff does come up, please hop in. We want this to be very interactive. As far as the education side, we'll kind of read through some of these big ones, but I know you all are well educated at this point. Some of the tougher ones that people run into. So binary is just this concept of black and white, right? Male, female, one or two. It is a system that we have kind of been accustomed to as far as a society that we're getting away from. Dead name, another term that you may hear kind of thrown around a little bit. So this was the birth name that the person has gotten away from. The reason why that is important, especially when it comes to inside the hospital, are we registering the patient as their legal name, their dead name that is now actually not their legal name, a mixture of their chosen name, and so getting that in place too. And you may have multiple records for a patient within our system too, if we have that kind of mix up, depending on when they came into the hospital throughout that journey, if they were going through a name change. That has happened.
Mhm.
All right. Gender dysphoria, we could have a whole lecture on just that. But the key here, so this is a DSM-5 diagnosis for psychiatry. The biggest piece is that there has to be two parts to this. So one, is there the gender incongruency, right? Born genetically male, but identify as female, wanting to have secondary characteristics of female, etc. That's kind of the part one, but that is just really what identifies us as transgender. The dysphoria piece is that does the depression, anxiety, mood symptom relate to this incongruence that the vast majority of transgender people do not have gender dysphoria. They may have a separate depression because depression doesn't care who you are, but is it that I am having this emotion purely because of this incongruence in kind of society around me? It can be really hard to discern sometimes because there is a lot of overlap. But just understanding that is something that not everybody who is transgender and is sad has gender dysphoria. We don't want to pathologize, normal human behavior. Okay. And the rest of these are pretty self-explanatory. The gender expression being more the outward appearance, how you want to identify yourself. Only thing I would add to that is that that may change based on location and kind of their situation, right? We act one way at school, we act a different way slightly at home, we act a different way a little bit more when we're visiting our grandparents that aren't as agreeable to this, or when we're in church with the family, etc. That may have some fluidity there, and it doesn't necessarily mean that, oh, you don't act this way 100% of the time, this doesn't count. It's not like that, that this is way more complicated than that would be. There's a lot more other factors here. All right. Another one that is you may hear kind of in pop culture here is more the gender queer, because queer has been kind of a term that has been taken back quite a bit by the community. But basically that they don't fall into these simple categories. So not even necessarily non-binary, but they don't fall into transgender female, transgender male, asexual, etc. To where they know that they're not necessarily cisgender, but they don't fall into these other pieces. It is also a term that you can kind of hear as an overarching, especially when patients don't want to go into it more deeply, or they may identify as even queer early on in their transition as they're really trying to kind of figure that out, right? Kind of, we see that when they're testing the waters, how's mom and dad going to react to this? And they kind of go on through that. We see that a lot more in the youth as well.
So gender queer, so my daughter's roommate identifies as gender queer, and her pronouns, their pronouns are they, them, but they dress female and go by Emily, and that was her given name.
Yeah.
So when I visit, it's very difficult for me, and I am literally exhausted after conversations trying to make sure that I keep everything straight. So I think someone earlier in the presentation said that the they, them pronouns are a little more difficult, and I can completely concur with that. So, you know, as we're talking about pronouns, you know, words are really powerful and really strong. Maya Angelou has a, you know, very well-known saying about, I'm paraphrasing here, of, you know, we're not going to remember what people say and we don't remember what people do, but what we do remember is how people make us feel. And words in the transgender population, our community, are very powerful. So which is why we're, you know, we're talking about that. And it's just that recognition, because the words give them that recognition that they are seeking. And these words here, you know, transgendered, he, she, you know, she, male, you still may hear those, and they are definitely used in a derogatory or hurtful kind of way. You know, transvestite, like transsexual and transvestite, I think were like the sexiest words back in the 70s, and you'll hear them in around Halloween for Rocky Horror Picture Show, but they're, you know, just not appropriate like anymore.
And on the transgender term, you know, it is one that we use more kind of in the medical community because it does fall into that, just like how we'll use the, you know, word like retarded to mean when things are delayed, right? How we have terms that are more okay with us because they fall within kind of that medical aspect, scientific aspect, but knowing more that in that community, when using this phrase just out in public, right, that is a very different thing than kind of in here. So to kind of clarify on that one, because it's like, oh, this is how it's written in the textbook, but it is a term that can definitely be offensive. All right.
And I think we talked about the identity versus expression.
Yep.
Yeah. So we'll keep going.
Some other big terms here. So passing, you'll use patients kind of talk about that. So basically this is how are they perceived by others, is the gender that they're trying to express. Is that how other people are actually taking them in, right? Not that am I tricking someone, but it's more kind of how that is kind of seen. And this is definitely very important for people. And it is also okay topic to actually kind of talk about, right? How do you feel that you are passing in public? How are other people treating you? How are people looking and talking to you in public? Because that's going to make a huge impact on their self-esteem and that anxiety, especially on the social anxiety side.
And then if you accidentally misgendered a patient, and I think we've covered that really well.
Yeah.
With the emphasis on like being genuine, apologizing, just right up front. And as Joe said, the person you're talking to may not have said anything, but they definitely recognized it. So self-correcting is also really important. And because, you know, first impressions are everything, you know, the front desk staff training is where some of that rapport and that trust begin, because we all work as a team. And so in our EMRs, whatever we can do to, you know, there's the legal name that maybe the insurance is under, or, you know, the formal medical record, but then how does the person, what's their preferred name? And then noting if that is somewhat different than the legal name.
Sticky notes.
Yep,
So
the sticky
stickies
notes.
that's there in Cerner can definitely be helpful there.
Well, can stickies be seen by everybody? How do we communicate that?
That's a good
across?
question.
Yeah.
Does anybody know that answer? Actually, I don't know if only I can see my sticky or if others. I know the patient cannot, and it's not in, you know, their online portal or anything.
I can usually see your stickies. It's just there's nothing that says that there's one there, so you have to be looking for it.
Okay. Okay. Yeah, so having that open communication, you know, when it does come to the front staff side, we should already have that training in place. But you know, when in doubt, if there's a patient that you know that is coming, you know, going from the inpatient side to the outpatient, never a bad idea to kind of have that discussion. Just, hey, such and such is coming. Here's the situation. Here's the pronouns. We're definitely going to do a good job to make sure we get this right. You know, that's very positive. And the front desk part is really important because that's the face of kind of the organization, right? This may be the first person they've ever met, you know, at Methodist, right? In this case, to where if that goes poorly, patients leave. That has happened where patients will end up kind of leaving the clinic because immediately they don't feel supported. They don't feel safe here. Why would I want to keep coming back here? So making sure that things are done correctly on the kind of right at the beginning, be that even having appropriate signage, you know, pronouns on your name tags if that's allowed. Not all places are allowing that. But having things that are supportive, be that the rainbow flag, the rainbow heart, simple stuff like that, it just gives that indication of like, you're safe here. It is okay.
Right, like on your
Yes.
badge, you've got the transgender pin, you have a rainbow pin. I usually have a pronoun pin on my lanyard, and it's a very small outward, I guess, sign that you're a safe person and recognizing.
And I've had patients actually on the inpatient psych side, how they've kind of, I guess, hinted me towards it, where they've kind of mentioned, I really like your pen, doctor. And so that's kind of like my hint of let's talk about this more, right? And I've had that happen on 3 occasions, I think, where we had no idea on the unit of the patient's identity, and then it's kind of they dropped this hint, knowing that they were comfortable, and then it opened up, you know, the entire conversation and what a lot more about the patient. So their care was greatly improved because of that.
Oh, that's great. So with a lot of this information we've kind of prefaced, and now we're going to on the data that, you know, we're going to share. Why does all of this information matter to you all, and why do we, you know, continue to talk about it now, you know, 3 years in a row? So why does all of this matter? So in a 2022 transgender survey that was completed, of the 79% of respondents who said that they had seen a healthcare provider in the previous 12 months, half reported that they had at least one negative experience because they identified as transgender. And those negative experiences were like being refused healthcare, being misgendered, having inappropriate language being used at them, or even to being, you know, perceived as being physically rough and abusive when receiving treatment. In an even more recent study that was completed, surveying 116 people who identify transgender or gender nonconforming, was a qualitative study, and 5 themes were identified. Acceptability, and this is, you know, again, talking about, you know, how powerful are words and being misgendered. Or being just outright refused care. Accommodation. So, and Joe, you kind of mentioned that, you know, the training for healthcare providers kind of across the spectrum has not been there. And so we're, you know, part of what we're doing is that education. There are some great training locations across the US, but they're not everywhere. So, and affordability and availability. So this gets into, I think part of it is that lack of training of providers, as well as insurance coverage, which has been over the past 10 years, 15 years has, you know, changes a lot. And then insurance coverage, is the person under 26 and they still have a good relationship with their parents? So do they have insurance coverage, or have they lost insurance coverage, or they can't afford it? And we're going to talk about some of those reasons why someone would not have insurance coverage. And then accessibility. Not everybody even offers specific care for gender affirmation care.
Yeah.
So there are some clinics in Omaha that are very specific, but not all places will even provide gender affirming
Yeah.
care. And that also feeds back to that accommodation of there are providers who just don't know and definitely would not want to, nobody should go to a provider who is not knowledgeable about the medications that someone would need to take and how to properly monitor their care and their dosing.
Yeah, and it's not even necessarily only medications. Obviously, medications being huge with side effects and risk and all that. But even I had a patient now 2 weeks ago who transferred to me because their outpatient provider before refused to write a letter of support, saying that they were mentally well and physically well enough to have surgery, not necessarily they should have this or not. Just are they able to have the surgery? And they just outright refused because I just don't do that. Like,
right.
What? Any doctor can do this. So what's going on? So that's a big problem. On the accommodation side, another thing to kind of sadly express that there is definitely a kind of generational change there too. Your newer grads are going to have a lot more of this education than your providers that were trained in the 70s, 80s, 90s when this was coming out to be new. Hopefully we're all keeping up with changes and things are updating, but as I'm sure you've seen, not everybody is quite as well read as everybody else, or do they want to actually have that education? So those differences are there. And when it comes to affordability with the ever-changing political climate, as far as kind of even Medicaid, Medicare, I'm not even sure where we're at now because it keeps changing, but are they going to support HRT? What are they willing to cover and what are they not? What can they get with, federal coverage versus private coverage through Blue Cross, et cetera. So very complicated for sure.
Or does it just come down to they have to pay out of pocket?
Yeah.
And and
those are options are there too.
All of those paying out of pocket.
All right. Pronouns we've talked about a lot. It's just kind of some of the examples. There are some really tough ones in here. One thing that is a good strategy if you are kind of making, your brain's getting mixed up, you're having problems there, go with the name. People like hearing their names, right? It's very personal. If you do it over the top, say their name 15 times, that's going to be a little much. But, if you do get in a spot where you're not really sure, your brain just kind of gets mixed, put the name in there, apologize for your stumbling, and kind of move on, right? We are people. We do make mistakes, but using the name can be a nice little kind of bailout if you are getting stuck in your head. Just don't overdo it. Then that gets obvious too. All right, here's some of the different ones, and more have even been added to this list since we put this up. I have run into a couple of them. Or I guess we had one before. Oh, Z, we at the bottom. The Zer I have run into before. They, them is a very common, obviously, our general, he, him, she, her, but there are some different combinations. For the most part, a lot of these are kind of more in the gender neutral, gender queer kind of realm, and you probably won't run into them, but these are just some of the ones that do happen.
So these questions are going to lead us into kind of our next section, but I would like to, what kind of health concerns might transgender individuals face and what challenges are pervasive across the community that the community faces? We may have touched on some of these already.
A big challenge that I ran into, I don't know, about 6 months ago, is we had a patient that was getting hormone therapy that was possibly causing some problems with the testosterone, and we had to ask them to take a break, and eventually it went well, but initially it did not go well, and they were at a specific clinic, and so it was I had a very big ethical dilemma on that because I wanted to support them, but wanted to have this conversation. So it was really difficult.
That would be a great case for something like this in the future years. We may come to you on that. Yeah, no, that is huge, right? Because we want to be supportive, kind of showing that we're not against you being on this medication. Here's our concern. So I think when that situation, the education side is key. right? Here's what testosterone may cause. And I imagine this was the mood swings, anger, agitation, insomnia, all the classics that we get with testosterone for any human being. So kind of educating them on that way, right? For anybody who takes this, here's the risk and here's what you're kind of showing. This is why we think this might be causing it. The other thing too, I think that's a big piece there is, are we talking about you being off this forever? Or is this just a right now thing? Are we saying no testosterone, never, ever again, you can't have this? Or are we doing this temporarily to try to figure out, is this what's causing it? What other factors are there in place? And when it does come to mental health, one of the big pieces too, as far as even starting HRT, is where's the patient at kind of stability wise before they go on the medication? So you can kind of use that kind of strategy to talk to them about, we want to get you back to where we're stable, and then we'll reintroduce slowly, because the biggest key is keeping you out of the hospital and keeping you safe and keeping you in the community. No, that is a really good case that we may have to talk about later. Anything else that jumps out to any of you guys? What about even on the substance use side? Is that something anybody's really thought about?
I feel like we definitely see a higher volume of folks with potential substance abuse issues.
Yeah, absolutely. And a lot of that, if you think about even the self-medication kind of aspect, if you have a population that does go through a lot more kind of difficulties and strife and challenges, naturally, as humans, we tend to lean into some of these not so great behaviors sometimes. So the more of the challenges you have, the more likely we are to have some of these negative kind of behaviors as well. Perfect. We'll talk about that in more detail. All right.
Great. So some of the demographics, so these are August 2025 numbers from the UCLA School of Law. They've got a Williams Institute that does a really great job if you go to their website. So these numbers are just tell a story of what is coming. And I think it's, really behooves us to think about these issues and the patients who are coming along. So in this, on the left side, the 13 to 17-year-olds in this, the blue, they make up 7.7% of the US population. But on the top bar, about 25% in this survey identify as transgender or gender nonconforming. And so if you look at the blue, the yellow, and the teal numbers, these are age ranges of 13 to 34. And they make up, what is that, 20, 25, maybe 30%, a third of the US population. But of that group, nearly 70% of the group surveyed identified as transgender, gender nonconforming. So,
yeah, so that age group. So much higher proportion of people that identify as transgender in that age group that are coming around, that are teenagers now, that will be adults very soon. Other thing with it too is that there may be an underreporting, especially in the older populations. We do see that. Is it enough to make up 20%? Probably not, but that number may be a little bit low. But yeah, definitely in the younger populations where they're more open to talk about this, a little more educated, especially as we get more kind of talking pop culture about sexuality and sexual identity that was a lot more taboo. You never talk to kids about any of this stuff.
Right.
Now is being out there and they're talking to their friends about this. Their friends kind of gender questioning, they're asking them about that. What's that mean? How did you know, etc. To where that it becomes more okay to have that discussion.
Right. More conversations. People are feeling more comfortable to be in their own skin and how they feel. And so these are good things. But they also bring with them, some negative experiences within the community. So just looking at the distribution, across the US of this the age group of 13 to 17 make up 3% of the US population. And this is kind of where they are across the US. So about 150,000 in the Midwestern area, but the Southern area, that's a big number down there. Just to comment on a little bit of the ethnicities that where these youth are spread across. And what I found the most interesting is the AIAN. So this is American Indian Alaskan Native as 4.2%, followed by Caucasian and then Asian Pacific Islanders.
And that's another topic that could be its own conversation for sure. But within the Native American community, we have like the two-spirited people, depending on what tribe you're in,
Right.
where this is kind of established in their lore of people that having kind of multiple kind of aspects to their personality and sexuality, to where it's a little more accepted, which I think that's probably partially why that number is a little bit higher. But really, too, with this, it's shown that it impacts everybody, right? It doesn't matter kind of white, black, American, Indian, you name it.
Right.
It is all over the place. And if we had a similar thing as far as financial income, you'd see that as well.
And so this comparison, so these are adult numbers. So this would be 18 and older, all ages 18 and older. So again, just bringing to your attention the 13 to 17-year-olds making up 3% of the US population, whereas adults who identify as transgender, gender nonconforming, not quite 1% of the US population.
And that overall statistic, that's something too that's interesting if you guys paid super attention to last year and the year before that. I think our stat from 2012, it was estimated around 1 million people in the United States. So now we're over 2 million, which I don't think is necessarily that the rate is any higher, because there's no reason to think that would happen, but more that actual being honest and being open about it and putting it on surveys and things like that, more of an identification bias, more likely.
Absolutely. Well, in research, if you start looking for it,
you find it.
You find it.
Exactly.
So there. Continuing with transgender people, they are more likely than the general population to be homeless and or underemployed, living at or below the poverty level. So this feeds into that affordability and accessibility with, do people have the money for out-of-pocket payment to see a healthcare provider or to purchase medications for gender affirming care, or is it covered with their insurance? Can they afford insurance? Are they on their parents' insurance, or do they have to try to carry their own insurance? And if you're unemployed, homeless, that's going to be very difficult. Talking about, racial ethnicity with transgender people. So 50% of Black transgender women, almost 60% of Native American transgender women, and multiracial transgender women have experienced homelessness. So this is a pretty big number. Males, so this is transgender female, are biologic males identifying as female, and they are 4 times more likely to be victims of a violent crime. And looking over the past 10 or 11 years of transgender people who are murdered, more than 85% of those were people of color and transgender women.
Yeah. And another one that we pulled from this, because a little bit outdated, but it was on the prior, was the study from France. I don't know if you remember that one from prior years, where transgender males in that case, I believe it was 27 times the rate of hate crime murders in France and the general population. And when it kind of comes to this one and that third dot, the 4 times more likely to be a victim of a violent crime, this does come up a lot more recently. And we're trying to be apolitical here, but it does come up more recently with kind of the recent gun crimes and kind of shooters that it has kind of been put out there by some organizations that rate is really high of being transgender violence, et cetera, et cetera, et cetera, et cetera, which simply is not supported by data.
For high school students, so this is going back to that number of 13 to 17-year-olds in school and some of the what they are experiencing, so feeding into and tying in with our case study. So with the youth risk behavior surveillance system, survey that's been going on for many years, the 1 out of 4 transgender, gender nonconforming youth experience violence at school. So, you know, there's a lot of correlation here with what people are feeling. Sexual activity may be decreasing, but some of the protective sexual behaviors like condom use or use of PrEP is not increasing, and feeding into some of the other risk factors that that affect the community overall. So with high school students, just a couple of things to bring to your attention here. So persistent homelessness and sadness is experienced by questioning and transgender youth.
Over 70%?
Over 70%, you know, while they're at school. Not feeling safe at school, and so they skip school. Seriously attempting suicide, making plans. So it's the transgender and the questioning who experience, you know, violence at school, electronic bullying, and as a result have more sadness and hopelessness, and may then look to suicide, if not other chemical or drugs to cope with how they are feeling. HIV infections. To make sure that we get through all of our information, kind of in a nutshell, the males, biologic males, are at the highest risk for developing an HIV infection. So in 2022, of the 67% of new HIV infections, those were gay, bisexual, or other men. And in that category, transgender women were 2% of those new infections, with transgender men being far fewer. So this is where our condom use, even though we've got, you know, less sexual activity in younger ages that's being reported, we don't have a correlating protection with condoms and or using PrEP, which is the pre-exposure prophylaxis.
Yes.
And PEP would be the post-exposure prophylaxis. And just some numbers here so even though people are getting tested, high numbers are getting tested. So 92% of transgender women were aware and getting tested. They're aware of PrEP. Only 32% of transgender women were actually using PrEP. And this ties back to, do people have insurance? Or is this something that has to be paid out of pocket? And these are not cheap medications. Okay.
Educate about risk, always the key.
Education about risk.
All right, and we'll kind of fly through a little bit of this. So we've hit on some of this. So the eating disorder rates are very, very high. This may be trying to kind of shape your body to your identified gender. So, so transgender females trying to change more of the masculine look into feminine. A lot of that is very restricted eating. We can see even on the other way, transgender males where we have overeating, steroid usage, heavy dose of testosterone, way more than they're prescribed, these type of things as well. Go on to the substance use. Oh yeah, we didn't get the substance use stats. I think we pulled the other, but substance use rates across the board, much, much, much higher. Pretty much rates of everything except for schizophrenia and bipolar disorder are elevated. And that is more because there's a much more stronger biological link to those than the kind of psychosocial. Psychosocial is definitely there, always, but the biological link is much stronger for those diseases than the others. But we can talk about that more another day, another complicated concept.
Exactly. So I think we've already talked about some of the EMR issues and going to the front desk. And we've also touched on already, I think, some of the issues with asking about, even though someone is outwardly presenting male, they may still be biologically female. And so asking about fertility, making sure that is someone trying to seek pregnancy or avoid pregnancy? Do they still need to have a mammogram? Do they need to have a pap or a pelvic exam? Do they have all of their parts, or have there been some surgical history where maybe if it's a transgender man, they do not have breasts anymore, but they still have ovaries and a uterus? So they still may need to have pregnancy tests.
Yes.
There's really amazing resources out there, and I have used the UCSF website for a lot of information. They've got great education, just Trans 101 in everyday work and life, acknowledging gender and sex. They also have a website that has a whole list of care, osteoporosis, cardiovascular disease, diabetes, and how does that affect the transgender population, also with some of the medications that they're taking.
And something for the WPATH being the one on the right there. I've been a member of that for quite a few years. It's excellent. Something that might be helpful for you guys. It has courses for one, but there's also a place in there where you can look up for various providers in your area that are part of the community. So if you need to find a therapist, a psychiatrist, whatever, right, you can go in there and actually look up, I need this type of doctor, here's the state I'm in. And they give you a big list of here's all of our people who are registered. It's obviously not a complete list of everybody who's, an ally or whatever, but it is a nice starting point if you guys are looking for that.
That's a great resource.
Yeah, it is nice.
So the Affordable Care Act and some of the federal workplace anti-discrimination guidelines, those have not changed. So I don't want to spend any time on this slide. I want to go to the next one, which is specific for Nebraska. I found this on the CDC website.
It's more stuff taken down. More stuff taken down.
Yes, so this is actually the CDC with a banner on their youth risk behavior surveillance system saying that the Trump administration, the current administration, doesn't even recognize that there is a transgender community. For Nebraska transgender laws. So the LB 574 bans gender affirming surgeries for minors. And regulates puberty blockers and hormone therapy. And so that was signed formally on July 2024 after the legal challenges. The newest law was signed in April 2025, banning transgender women, student athletes, from competing on sports teams that match their gender identity. So, and the reason I wanted to bring awareness with this is it's going to be more in the news as we have Olympics.
Yeah.
In the Summer Olympics 2 years ago, it was brought up, but now for the Winter Olympics, I think that's going to become even more of a question that we'll see in the news. But just so you know that Nebraska has recently passed that law with regard to transgender women on sports teams.
Yeah, and they're similar throughout the country.
Mm-hmm.
Okay.
So that's kind of the end of the overview of our presentation.
There's a lot of information in a short period of time. Questions from any of you guys? Anything we didn't answer? Obviously, you're welcome to reach out And also we do have more resources, including some local resources as well. If that's something you'd be interested in, you have access to our email. Please just send to my, this is joseph.kent@nmhs.org, and I'm happy to share or answer any other questions.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.